We're going to talk about a topic that sits right at the intersection of oncology, reproductive medicine, and ethics: oncofertility in women. This is about how we preserve fertility and hormonal function in women diagnosed with cancer without ever compromising oncologic safety.
And it's an essential topic because with improving cancer survival, infertility and premature menopause are no longer rare side effects. They're long-term survivorship issues. Yet fertility is still too often forgotten at diagnosis.
Let's start with a simple question. Why does oncofertility matter so much? The answer is that more women are surviving cancer during their reproductive years, and many of them will live decades with the consequences of treatment-induced infertility or early menopause.
Exactly. And fertility isn't just about having children. Loss of ovarian function also means early estrogen deprivation, which affects cardiovascular health, bone density, sexual health, and mental well-being. So preserving ovarian function can matter even when pregnancy isn't a goal.
Oncofertility is not a single procedure. It's a multidisciplinary approach that integrates oncology, reproductive endocrinology, gynecology, surgery, radiation oncology, and survivorship care.
And an important point here, oncofertility is about preserving options, not making promises. We can't guarantee pregnancy. What we can guarantee is informed choice if we act early enough.
Let's talk biology. The female ovarian reserve is finite. Women are born with all the oocytes they will ever have, and once those follicles are destroyed, they don't regenerate.
Chemotherapy accelerates follicle loss through DNA damage and apoptosis. Radiation is even worse. Oocytes are extremely radiosensitive. Pelvic radiation without protection is almost always sterilizing.
And age is the key modifier. A 25-year-old and a 40-year-old exposed to the same treatment won't have the same outcome because baseline ovarian reserve is completely different.
There's another organ we forget to talk about, the uterus. Even if ovarian function is preserved, radiation can damage the uterus, leading to miscarriage, preterm birth, and placental complications.
So, fertility preservation is not just about ovaries. In pelvic radiation, strategies like ovarian transposition and, in selected cases, uterine fixation can meaningfully reduce reproductive harm.
Here's a high-yield message for anyone listening. All reproductive age cancer patients should receive fertility counseling.
Regardless of age, parity, prognosis, or whether they say they want children, counseling is not the same as intervention. Even when patients decline fertility preservation, counseling reduces decisional regret.
And most patients won't ask. Diagnosis shock, fear, and time pressure silence these questions. So the responsibility lies with clinicians.
Timing is often presented as the problem, but in reality, late referral is the problem. Most fertility preservation strategies can be completed if referral happens early.
Oocyte or embryo cryopreservation usually takes about 2 weeks. That time can often overlap with staging, imaging, and treatment planning. And when time is truly limited, alternatives exist.
Let's quickly review the main options. First, oocyte cryopreservation, the gold standard for post-pubertal women. It preserves autonomy and doesn't require sperm.
Then embryo cryopreservation, also highly effective, but with legal and ethical considerations since it requires sperm at the time of preservation.
For urgent cases or pre-pubertal patients, ovarian tissue cryopreservation is key. It doesn't require stimulation and can preserve both fertility and endocrine function.
And for pelvic radiation, ovarian transposition can dramatically reduce ovarian radiation dose. It preserves hormones more reliably than spontaneous fertility, but it's still incredibly valuable.
What about medical ovarian suppression with GnRH agonists?
Important point. GnRH agonists are adjunctive only. They should never replace established fertility preservation methods when those are feasible.
In early-stage cervical cancer, fertility-sparing surgery, like conization or radical trachelectomy, is safe in carefully selected patients.
But lymph node status is decisive. A positive node means fertility preservation must be abandoned. Oncologic safety always comes first.
In ovarian cancer, fertility-sparing surgery is even more selective, usually limited to FIGO stage 1 disease with favorable histology and full surgical staging.
Oncofertility only works when teams work together. Oncologists start the conversation. Reproductive endocrinologists assess feasibility. Surgeons and radiation oncologists plan protective strategies.
And survivorship teams ensure long-term follow-up. Fertility preservation doesn't end when cancer treatment ends.
Let's name a few common mistakes. Assuming a patient is too old, waiting for the patient to ask, relying only on GnRH agonists, or skipping documentation.
And perhaps the biggest pitfall? Thinking fertility preservation is optional. It's not. It's part of standard ethical cancer care.
So let's end with 3 messages.
First, always ask. Never assume what a patient wants.
Second, counsel early and refer early. Timing determines everything.
And third, preserve options, not promises, while never compromising oncologic safety.
Thanks for listening. We hope this helps you integrate oncofertility into everyday clinical practice.
See you next time.